Excuse me, everyone. We now have all of our speakers in conference. Participation in this call is by express written invitation of the AHA only. Unauthorized participants and or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call if the AHA did not expressly invite your participation. Please be aware that each of your lines is in listen-only mode. At the conclusion of the presentation, we'll open the floor for questions. I would now like to turn this conference over to Drew Solo. You may begin.
Welcome, everyone, to today's webinar. This is Drew Solo with the American Hospital Association, and I'm pleased to be moderating today's event, Identifying Improvement Opportunities for Our Telemetry Monitoring Program. Huntsville Hospital System optimizes process to enhance patient care. This webinar is brought to you through the generous support of Phillips. During today's webinar, Huntsville Hospital and Phillips will discuss a telemetry monitoring program assessment that was conducted to identify performance improvement opportunities in telemetry utilization and alarm management to prepare for hospital-wide installation of new telemetry monitoring equipment. They will discuss the elements to include in a current state telemetry and central monitoring unit, CMU, assessment in order to map and evaluate the end-to-end telemetry monitoring and alarm management process and practices, determine the impact of current telemetry utilization on costs and throughput, and review areas working well and existing gaps and barriers. Key findings and selected improvement opportunities focused on enhancing patient care and safety, reducing workload and non-actionable alarms, and supporting throughput by better using telemetry will be shared. Finally, some frequent seen CMU challenges will also be reviewed. Please take note you may submit a question for our speakers at any time in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. With that, let me briefly introduce today's speakers. Wendy Cottrell is the manager of cardiac telemetry monitoring at Huntsville Hospital System in Huntsville, Alabama. Wendy and her team are focused on providing the safest, most professional, and quality-based and intentional cardiac monitoring services for all patients at Huntsville Hospital with telemetry orders. She serves as the manager for the Cardiac Telemetry Monitoring Department, a centralized monitoring unit that serves over 375 patients daily. She has also been a cardiovascular education specialist for Huntsville Hospital for over 33 years. Wendy serves in the faculty for the hospital's corporate university as part of its multidisciplinary teaching staff. John Zavanzo is a consulting manager at Phillips with the Acute and Critical Care and Performance Improvement Team. John is an expert in the hospital operations, workflow, and process redesign. He has led a number of projects related to telemetry optimization. He is a fellow in the American College of Healthcare Executives, and he's a regular presenter on various topics, including healthcare efficiency and the use of simulation in healthcare. His clinical expertise includes emergency care, pre-hospital care, and pediatric and adult ICU. Dale Roberts is a senior consultant at Phillips. Dale brings expertise in reducing non-actionable alarms, increasing workflow efficiency, best utilizing technology, and improving CMU processes. Her clinical experience includes critical care, trauma centers, geriatrics, and public health. Her clinical expertise includes experience as a clinical specialist for Philips monitoring and analytics clinical services with over 32 years of experience at a level 1 trauma center as a critical care nurse and nurse practitioner. It is now my pleasure to turn the floor over to Wendy, who will begin our presentation.
Thank you. Good afternoon, everyone. I am Wendy Cantrell, and I wanted to share with you just a little bit about the program here at Huntsville Hospital. We are a not-for-profit hospital system located in North Alabama, the second largest hospital in the state. We serve as a regional referral center, a level 1 trauma center, and a teaching hospital. We have about 329 telemetry monitoring sectors at our main campus and are set up as a centralized monitoring unit. We also, in the cardiovascular areas, we have 3 ICUs for cardiac, 5 cardiac nursing units, and a step-down surgical unit. So I'm very happy to be on the call today and share some great information with you guys.
Good afternoon, everybody. I'd like to add my welcome to Wendy's and thank you for joining. Phillips Healthcare Transformation Services is the consulting practice inside of Phillips, and the goals that we have are to deliver solutions that are oriented and that are solutions oriented and people focused to help improve clinical care, patient experience, operational effectiveness, and financial performance. These are just a few statistics about HTS. We have over 60 consultants based in the United States, and 100% of our consultants have had hands-on experience inside of their roles and working inside of their domain areas. We also have a global reach where we have clinical or consulting practice in about seven different countries.
I wanted to give you a little background to show what led us to our assessment process. In 2018, we were preparing for 2019 to plan a very much needed upgrade to our telemetry system. We'd been limping along for several years with some chronic issues to our telemetry problem. We had grown and grown. We had too few monitors. There was often a waiting list for monitors, which we did not like that at all. We would have to prioritize often which patients to put on telemetry. We had broken monitors that we were unable to get parts for, and sometimes our system would overload and would go down, and we would have to go on a downtime procedure protocol, which again was not optimal. We wanted to be able, when we went live with our new upgrades in 2019, to take full advantage of the new technology. So we sought out Phillips to do the consulting assessment with us so that we would know what improvement opportunities were out there prior to the upgrade so we could put those needed changes in place.
So as we looked at this is kind of a quick overview of the engagement and the partnership we did with Huntsville Hospital. You know, the challenge that was here was the need to evaluate the telemetry and central monitoring unit and look at their alarm management practices so that we can make an impact on the number of non-actionable alarms that they had. There were obviously some time constraints that Wendy just went over that were, tied to their new telemetry equipment. So our solution, Dale and I, had a collaborative consulting engagement there where we did a lot of in-depth analysis on workflow. We did some in-depth dives on data, and we also spoke with staff and other key stakeholders in order to really get a good idea of the root cause of the issues that they were having, so that we could make some good recommendations to them for prioritizing change and recommendations. This is just an idea of how do we come about the engagements that we do, and a lot of times it is because of questions that are asked to us directly by our clients or to other parts of our Phillips team that get referred to us. And once we're engaged, a lot of times we go through a series of steps to decide how to look at the project. In this case, as far as the telemetry project goes, there's a light blue box that talks about reducing the overuse of telemetry there on the middle of the slide, and so that was important here. And then how do they safely transition to a central monitoring unit model? Now, in this case, Huntsville already had a central monitoring unit model, but they were looking at how could they possibly improve that model and make it more efficient. So these are just kind of large-scale ideas of things that our team will look at inside of our engagements. Once we move into the engagement, we have an assessment model that we do, and we usually break it into 3 phases, or phase 1, which is a current state assessment, and then there's a transition phase where oftentimes we will work with the hospital to create a new design, for a new piece of work. And then in phase 2, we will help trial that design and look at implementation results both pre-work and post-work. And so we can give some hard data on the impact of the work that we did. Now, in this particular case, it was a little bit different because Huntsville engaged us to look strictly at the phase 1 piece, but we also worked very closely with our implementation team and installation team. So we shared this information with them so that they could collaborate with Huntsville in order to make changes before their new telemetry system was even brought online. So in this case, these are the areas that we review in any part of our assessment process. Now, we start with these areas and then we will deep dive any specific workflows that we identify or in that people section as we do interviews and staff surveys. Those workflows that get identified as problematic, we will deep dive those. So each one of these assessments is actually customized to the area where we're working. The results of the assessment are shared with the client, and in this case, also with our implementation team to help them build out the changes that Huntsville wanted, like I said, before the program was even brought together. Now, in this case, we looked at the CMU, we looked at the 6 West unit in PCV, and also in 2 West. And Wendy, do you want to talk about how we decided on those units?
Sure. We chose these 3 areas that we felt would give us the best slice of true data and common issues that we were facing. The central monitoring unit, of course, so that we could take a look at alarm management in the room as well as workflow issues. We chose the 6 West PCV unit as a surgical step-down area, very high use of telemetry, of course, and the acuity of the patients there is relatively high as well. And then we chose a non-cardiac but high telemetry user unit, which was 2 West. And so we felt like, again, that would give us a very good slice of life and great data to work with if we could glean things from these 3 areas.
So the next step that we have with our project goals and objectives are to identify, what those large scale goals and objectives will be with the client. This allows our team to focus and deep dive the areas that are of most concern to the hospital. In this case, in Huntsville, a good example was some of the discussion that Wendy just had of what areas were we going to look at in the time that we were there. This also allows us to discuss findings in real time during the assessment in case we identify a new area or a new workflow that the hospital may want us to take a look at while we're on site and observing what they did. In this case, the large-scale goals, we're looking at the data analysis. Patient safety is always a goal. We want to make sure that any work that we're doing or any changes that we make, the safety is paramount. We wanted to look at standardization. We wanted to reduce non-actionable alarms, and we wanted to help improve the amount of telemetry use to make sure that the patients that were on telemetry were actually good candidates for telemetry. As you're bringing this back up, you can go to the next slide.
All right, so
while technology has evolved over the last 55 years,
The origins of telemetry began with the NASA and the space program. And what a privilege it is to be presenting this with Huntsville Hospital, because that is where the rocket scientists for NASA live and work, and also where the internationally known space camp is located. Telemetry comes from the Greek word tele, meaning remote, and metron, meaning to measure. Broad adoption of telemetry occurred without specific guidelines until the American Heart Association and the American College of Cardiology established guidelines for appropriate use of telemetry. The cost of inappropriate use of telemetry can be increased length of stay, increased cost, increased for unneeded testing, as well as noise, increasing staff hours, and creating more work for the staff. Wendy, do you have additional things that you want to add to this?
Yes,
Like
thank you. Plug for the Rocket City that I grew up in. Just as a point of interest, I think when we really started taking a hard look at all of this, we found something we didn't know. There was some aha moments along the way. We had telemetry orders embedded in over 130 care plans, or power plans, we call them. And we were finding that many of the physicians, the hospitalists, were ordering telemetry unknowingly for their patients, which sort of goes back to you need a good physician criteria program so that you can guide that process a little better. So we had no guidelines at that time. Any physician at any time could order telemetry. And again, some were ordering it unknowingly by selecting the power plan, and overuse of telemetry, we found, was the result. Another thing that came to light was with our old system, we didn't have a lot of flexibility to divide the sectors evenly to keep our tech to patient ratios where they needed to be. For example, we would have one station with a technician trying to watch 50 or 60 patients, and then right down from them, someone could be at a station with 30. So we didn't have a lot of flexibility with how our sectors could be set up. And then probably one other thing that we were doing that we've modified is we had a system where we have what we call our runner or floater position for the day, and they were trying to page out alarms from 6 technicians, calling out those pages to them, which began to get overwhelming as well because of the alarm fatigue, for lack of a better word, the overuse of alarms. So we'll talk more about that as we move forward.
So there are other impacts of overuse of telemetry, and there's been some, there's been some very good research done. You can see that we've got some references down there at the bottom. During this particular engagement, while we were at Huntsville, we did a live audit on the second floor units over 2 weeks. And so we actually reviewed telemetry care and reviewed the telemetry orders and reviewed telemetry discharges. And when we looked at this, what we found, as we looked at the teleutilization days versus the recommendations of the American Heart Association and the American College of Cardiology, is really only about 10% of the patients that we looked at were folks that had great criteria to be on telemetry. And so as we extrapolated that out, there was a lot of added nurse hours that were used in unnecessary telemetry care. And we were also able to take a look at the nursing time as far as cost for telemetry overuse. And you can see that that's kind of outlined here. And this is based on the American Heart Association criteria that was published in 2017. And one of the quotes that comes out of there is the need for continuous electrocardiographic monitoring should be reevaluated at least every 24 to 48 hours. That was another gap that we saw while we were there that I know was reviewed as part of our recommendations. So as we start to do workflow analysis, and I know that the smaller pictures may be difficult to read, but the workflow analysis is customized in the initial design and scope of the project. These are some examples of the areas that got customized in our team and our report for Huntsville. At the beginning, we always request policies and procedures that are relevant before we go on, before we assess the site. This allows our team to examine actual practice through the lens of established policy. We can also examine current practice in light of leading practices, so we can take a look at what's being done versus what has been recommended in the literature and make recommendations based on that, which we did at Huntsville. You can see that down in the right corner. It's often easier to show workflow gaps using a mapped out workflow. So in the upper right corner, you can see where we did a failure point mapping. This was part of the communications piece that we delivered at Huntsville. And we also identify potential gaps in real time. Sometimes we do this using pictures, as you can see in the lower left. And we also tie that back to, leading practice or, recommendations that actually go with the hospital's actual policy and procedure. Kind of going on, we also do a lot of work as we do these projects, looking at the view of the staff and with key stakeholders. In this case, we talked with bedside staff all the way through executive leadership. We also did a staff survey, and this helps us a lot of times to see how practice evolves and be able to, kind of reflect back to the client how their practice has evolved, even if they didn't realize all of the evolution that has been made. These interviews for the team that goes on site clarify a lot of questions. I often tell people as I'm doing these interviews, yes, I'm an expert, but I'm not necessarily an expert in your house. And so what I need to understand is, why the practice is being done the way the practice has been done so that we can make recommendations. Sometimes about 80% of the time, we will understand, even though we look at it, we scratch our heads and go, hey, why'd they do that way? Once we get through these interviews, we have a good understanding of how the practice has evolved and why it's done that way, even if it doesn't match up exactly to what's in the procedure.
Again, some small slides here, but what I think you can pick up from the pictures is that in the assessment that we did, we determined that very few of the alarms that they actually had were what we call the red alarms or the high priority alarms. And they only amounted to about 3% of the alarms that they were receiving. A good percent, about 35 to 50, depending on the unit, were yellow medium priority alarms, which were basically non-actionable. They were things that, yes, it was nice to know, but you didn't need to take action on. And then another high hitter for them was the ECG leads off. So most common alarms that Huntsville had were ECG leads off, a pair of PVCs, and the high heart rate alarm. And we looked at those alarms, and we estimated based on a study done by Christiana Care that if we had turned off some of these medium priority alarms, they would have been about close to 40,000 less alarms during the study period. Wendy, would you like to elaborate on some of this, or did I sum it up pretty good?
You did a great job. I would just add that what had begun to happen inside the telemetry room, if anyone has a central model that they use at their hospital, is your technicians were spending time playing whack-a-mole, my word, but
whack-a-mole on the non-actionable alarms to the point that they often could not focus as well on your medium and high priority alarms that truly needed attention. So well stated, though, what you found when you evaluated ours.
So after we go through the whole assessment process, we look at that, our team looks at that and comes up with opportunities. In this particular case, we then prioritize those opportunities. In this particular case, we identified 25 total opportunities, but really the largest impact and the largest bang for your buck, if you will, we're looking at the top 7. And I know that's an odd number, but as we played with top 5, there was a couple of these that just, we couldn't drop out and, make sense as far as priorities. So the number 1 was modifying the medium priority arrhythmia alarm settings. And that's what Dale and Wendy just referred to. And that drop in the amount of non-actionable alarms that was potential there. The second opportunity, with the highest prioritization was looking at the telemetry utilization, and it kind of goes with number 3 with continuation and discontinuation. And as Wendy referred to earlier, they found 130 power plans, that had telemetry orders embedded in them, where rather than making a conscious decision about a patient going on telemetry, it was very easy for a physician, through no fault of their own, to just choose the power plan and have that order already pre-checked, if you will. Number 4 was the ECG leads off, and this is a common finding, and it's also kind of a difficult one to tackle. So when we look at that usually requires some level of practice change, and we can make recommendations to help with that. Electrode changes in skin prep, there is a lot of literature out there that talks about how you can eliminate a lot of alarms through appropriate electrode changes in skin prep. Customization of alarms was the 6th area that we thought could make a large impact for Huntsville. And then number 7 is something that we recommend for just about any hospital, and that is to establish an alarm committee that keeps this information fresh and keeps practice, reviews practice at least annually on how you're managing telemetry and looking at alarm data to be able to make some of these recommendations on a continual basis.
We were amazed at some of the data we were able to review after our assessment. 156,000 alarms in 29 days on just the 2 nursing units in our pilot group. That was just staggering to us. And, of course, it helped us to want more and more to use this assessment data to get that number down. Some of the parameter changes that we were able to consider, simple things like changing your PVC count from 10 per minute to alarm to 15, reduced by a significant number of alarms monthly. Changing your heart rate limits, high-low, removing PVC pairs and multifocal, because if you set your ventricular alarm to greater than 4, you'll capture that anyway, so that was helpful. Removing the pause, that was one that was alarming off, and we set the asystole setting to greater than 3 seconds, so we caught that there. So there were all sorts of alarms that we were able to either remove or change parameters on. One of the ones we removed was irregular heart rate, as I mentioned, the pair of PVCs and all, because we could catch those in other ways. We also went through a process, of course, to look at our policy. We had to make sure that our policy matched our new practice, and we did see a significant reduction in non-actionable alarms in the central room. Noise level, amazing to watch the noise level decrease. And I feel that my technicians are able to be much more intentional in their monitoring with less noise and less alarm fatigue. As I was just talking about, basically on this slide, we just sort of encapsulated here that we were able to look at the 25 opportunities that John mentioned and then customize and select the ones, as he stated, that we felt were very doable, were very much needed at our organization, and we loved being able to take that list and say, you know, these are the ones we want to focus on now, and we've kept that list so that if we in the future we want to focus on other assessment data points, we're able to do that. We had real data for the first time to present to our medical director and our leadership. Instead of taking what we thought was happening or what we had, you know, concerns about, we now had real data that was driving our decision making, and that was great. Some other uses that we had for our consulting information, we presented 3 options to our medical executive committee based on the AHA guidelines for selecting patients for telemetry use, and that was really helpful as well. We removed telemetry from all the care plans that we mentioned earlier with a few exceptions. We left telemetry pre-selected in all cardiac, neuro, pulmonary, and ICU power plans. We felt like those, our medical team felt that those needed to remain as they were. For all the other areas, the provider, when he goes in to select telemetry, it will do a pop-up box for him or her, and she can then select from the AHA guidelines before placing the patient on telemetry. And by reducing that number of patients on telemetry and reducing our non-actionable alarms, again, I would just state that my technicians are able to do safer, intentional, and very purposeful monitoring, and that has been a big win for our technicians. I think the job enjoyment went up. I know the safety went up, and so we're very happy with these results. I thought I would share just a little bit right here about our process as we led to all of this. We began planning for our upgrade well over a year out. We had a task force that we compiled with our cardiac leadership group, our nursing directors and educators from units and floors that are impacted by telemetry use, and of course our medical director. We met quarterly throughout that entire year, plus anytime we felt like we needed an impromptu meeting. Our medical director was very helpful to guide the physician side of the project, and he served as a champion for us to go back to our medical staff and be able to communicate that very well. About 6 weeks prior to our anticipated go-live date, as we've termed it, we held a staff skills fair, and Phillips was great. The Phillips trainers came to be with us, and my telemetry trainer and I, we were able to reach and train over 800 employees in 1 week. And we were able to give them an opportunity to touch and feel and see the monitor, the MX40, to get to play with the functions and gain some comfort with that. We talked a lot with them about the advantages to the upgraded PIIC system. And that was just really key, I think, to success, is getting other people, our other staff at the hospital, excited about the change. We had educational materials that were sent to all of our hospital educators, and they posted announcements. We had things on our intranet page. We had mandatory training, of course, for all the telemetry technicians, And we even offered to go to all staff meetings for the floors and review and take the MX40s and, again, give them some time to touch and feel and play with the buttons and become very, very comfortable. Go Live Week, we had daily updates for all the hospital leadership on our morning safety call. We had huddles with the team throughout the Go Live Week, and we compiled a daily checklist of completions and then also any barriers that we felt we needed to work on before we could move forward.
So as we looked at this engagement, one of the things that I get asked oftentimes is, what does it take to wind up having to have a successful assessment and then a successful project? And one of the things that was very clear here was how engaged Huntsville was, from their leadership team, on down to their staff. Sometimes it gets difficult to get interviews and that kind of thing. Huntsville made it a big priority to get involved in this. And Wendy, I've got to hand it to Wendy as our point of contact there. I have never had an easier time working with a hospital as I did with Huntsville, because we just had a great relationship with our point of contact the entire time. This was a little bit different. Like I said, we engaged our Phillips installation team, and it was a little different. We often worked together, but not as closely as we did on this particular project, and they were also very engaged. We had a relationship, with the local leader of that team, and he went out of his way to make sure that this information moved freely between Huntsville, the HTS team, and the installation team, and just did a great job coordinating it. There was a lot of organizational transparency on the part of Huntsville. When we asked for information and when we did interviews, we got the unvarnished version of what was happening, which helped us prioritize and make the right recommendations. They did a very good job, with planning, training, and communication, and their staff. Like I think I mentioned, their staff engagement and openness. Especially their night shift. Sometimes it can be very difficult. We do off shift and weekend work when we do these assessments, because sometimes what happens during the day is not exactly the same as what happens at night. And sometimes it can be difficult to engage night shift staff, especially if you ask them to come in early or stay over. But the staff in Huntsville was just so engaged in wanting to see this improve. It was very helpful. Dale, Wendy, do you guys have anything you'd like to add?
I think you made a good summary there. Yeah. Go ahead, Wendy.
Excellent. I was just going to say that the daily huddles that we had with the entire team from the Huntsville side and the Phillips side was, to me, a key factor of success. One of the goals that we had was not to have a successful go live, but to have 0 patient harm events during a go live. And we had that as our priority every day, is how can we do this and make sure patient safety remains number one. And we would get together every morning before we launched for the day. We would talk about how did it go yesterday, where were the barriers, what can I do. It would give me a punch list so that I could go back to the office and start contacting and doing a little front-end work so that when the installation team got to certain areas, they knew they were coming, they were ready. We did run into a couple of barriers along the way, such as maybe we needed to get into a patient room to replace a sensor, but that room was on precautions for some reason, and we didn't have another room to move them to. So we faced a lot of those type of situations as we rocked through the week, and we were able to just say, okay, let's go and do something else, and we'll come back to this one. And we just, just good communication, like John said, made the difference all through the week. One of the questions that Dale and John were asking me about before we were getting ready for this webinar was, had we noticed anything about COVID-19 impact with our new system? And the two things that I think jumped to mind immediately for me were that we had to do some impromptu COVID overflow units in our hospital, as I'm sure many of you have had to do as well. And in our old system, we would not have had the capabilities to have a seamless transition and move those sectors around and make sure monitoring could occur for those patients. So that was one big plus to having our new system in place. Also, the wave export function, being able to save and send to the patient's electronic medical record was just invaluable. The physicians and nurses, no matter where that patient was moved, could see their telemetry, their strips, their alarms, anything that we needed to communicate to them along the way.
I think that the Phillips consulting engagement allowed the Huntsville Hospital to determine how they wanted to proceed with this new installation based on data and best practices. Working together with the local install team and knowing which alarms were triggered most often and non-actionable allowed leadership, then the physicians and the staff, to determine what is the best practice for their patient population. When I asked Wendy how she and Huntsville felt about this, she said the outcome basically was a reduction in noise in the CMU, a reduction in the amount of calls to the staff, and less interruptions in care. I'm now going to turn this back over to Drew for our question and answer period.
Great. Thank you, Wendy, John, and Dale, for your presentation. We'll now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining, and questions that are unable to be answered in our allotted time will be shared with the speakers for follow-up offline. So first question, Dale, question for you. Can you share just overall best practices for multi-hospital systems and monitoring from a CMU?
Well, I think probably the best answer for that is to develop and update your current policies and procedures that meet the American Heart Association and the American College of Cardiology guidelines for telemetry monitoring. And then, as Wendy emphasized, educating the staff, incorporating the guidelines into future electronic ordering systems for EMRs might be helpful. Look at where you want to standardize and what escalation protocols you want to implement. Where are the commonalities? I think those were probably the key points. Wendy or John, do you have anything to add to that?
I do not. Dale, I think you did a good job.
Yeah.
Great. A question, John, for you. John, what is the ratio for monitor techs to number of patients being monitored?
Well, that's a good question. When we look at the data in the literature, there's just not a ton of research that's been done around how many sectors or how many patients can a monitor tech monitor. Siegel and his associates at Duke took a look at this using simulation, and they found that anytime you had a monitor tech that was watching over 48 sectors, their average response time, to an alarm went from 0.13 seconds to 13.7 seconds. So that's obviously a significant change. And when they looked at that, they made the recommendation that the absolute top end should be 48 sectors. But if you actually look at the research and read the article, you will find that they were much closer to 40 sectors as the recommendation for the highest number that somebody should be watching at any one time.
Great. Wendy, I have a few questions for you here. Wendy, what are your staffing recommendations for monitor techs?
Well, like John said, I tried to use the recommended 48-to-1. We are now under 48 on most of our stations, which is great. When I'm fully staffed in my central monitoring room, I have 8 techs on duty monitoring at stations, and then we have what we call a floater or runner, we sort of refer to them, for the day, who support the other staff, relieves for breaks, cleans monitors, does things that, keep our other techs from having to get up and be away from their stations. For call-outs, we developed a PRN pool of employees back quite a few years ago. We also use a call list. The PRNs can sign up to be the on-call, and they are paid $2 an hour to be the on-call, and if they get called in, if their name's on the list, they are obligated to come in because they've been paid the call pay. So that has worked very well for us, and I would recommend that as a great solution to keep from working short.
Great. And Wendy, you touched on this at the end, but have you changed your protocol to include COVID-19 patients as a group that gets placed on telemetry?
We really haven't changed how they are placed on telemetry. I would say we still follow the same selection criteria. The physicians can certainly select that. Most of those patients are on, a respiratory power plan, which already has telemetry, or a lot of those patients, I guess I should say. As far as the cleaning of equipment, we made the decision that we will treat all monitors returned to the central room as COVID positive. There's just really no way that you can be assured that, you're not using the right protocol with the right monitor. So we just made everything COVID positive cleaning strategy. And then again, I'll mention the wave export capability has been great because we can make sure that the physicians and the nurses have what they need in the electronic medical record as soon as it occurs and can review that real time.
Great. Dale, a question for you. What is the best practice for getting telemetry discontinued proactively?
Well, I think probably the most in the literature that they cite the most often reason for telemetry continuing to be used inappropriately is either lack of awareness of the guidelines or just plain non-adherence. They just find the guidelines very complicated. If you've looked at the document, it's about a 60-page document. So to break that down into a simplified form is probably your first step, and then use the possible tools that you might have to enhance that. For instance, a PowerPoint presentation to your physicians, your nurses, your nurse practitioners, residents, maybe posters throughout the institution highlighting the indications for telemetry. Order entry, automated order entry would be great, but sometimes we have to pay for upgrades to our electronic health records and have to do it on a schedule. So we might want to put that in your wish list for electronic order entry. One of the things that we have sort of, and questioning staff seen, is that RNs generally are not comfortable with making the call to discontinue the monitoring. In my practice with Phillips, several places say, well, RNs have the right to discontinue, but when you actually speak to the nurses, they're just not comfortable making that call. So that is not one of the practices that we necessarily recommend.
Okay, great. Wendy, what is the escalation process for non-responsive staff to telemetry calls such as leadoffs?
The escalation process?
Yes.
Our escalation process is that we page initially, for example, leads off. check monitor, and then if our paging bridge is set up that if after 4 minutes that page has not been canceled out by either the technician or the nurse, it will auto-escalate and it will page it out again. After 4 additional minutes, if not closed out by either the nurse or the technician, the patient care technician, then it will escalate one more time, and it will also send that page to the charge nurse. If by chance it's not handled at that point, that is a phone call to the unit director, and my telemetry supervisor calls and talks with the charge nurse until we get it fixed. If necessary, I will even send my runner, floater, physician person, and we'll go up and do it ourselves.
Great. Another question for you, Wendy. Do monitors stay with patients throughout the transfers, or are they reassigned at each unit?
That's a great question. We have 2 units that our monitors are actually, we call it married up to the room. Those are the step-down unit for the surgical open heart cases. Each one of those rooms has a monitor assigned that never changes. They keep and do their own monitors on that floor, and I have a tech that sits at that station on the floor with them. The same situation applies down in our cath lab area. The monitors there are assigned to the patients that are there for catheterization pre and post. As far as my others, the way we work it is, for example, if I have a patient that is moving from 758 on the 7th floor down to the 3rd floor, then the monitor can go with the patient. Because of the sector capability is so fluid, we can pull that sector over and reassign the room number, and they can keep the same monitor.
Great. And Wendy, actually another question for you that I thought was interesting. What do you require for hiring monitor techs, CNAs, PCTs, and what is the length of training for them?
I love that question since I'm an educator myself. We hire no experience. We have always hired in with no experience. It is preferred. If they have a little bit of medical, it's always helpful, but we don't find that to be a deterrent. Once you are selected, and I have some selection criteria I'd be happy to share with anyone that would like to have it. But once you're hired, we have a 4-day training course taught by myself and my trainer. And it is from the ground up, the physiology of the heart, the electrical system of the heart. We go into where certain rhythms originate, of course, learning all your rhythms, your lethals. And then once they've completed that course, they are placed with a trainer. And their trainer and that employee work in tandem for the first 4 to 6 weeks. We do not let monitoring techs sit alone for at least that amount of time until we feel that they are comfortable, and then they are required to pass a competency examination before they can sit solo.
Okay, great. Wendy, I actually have another question for you. Wendy, how does your organization ensure that calls from techs are answered and addressed in a timely manner? And is there an ideal time frame from when a technical alarm occurs, for example, a lead fail, and when it is corrected?
That sort of goes back to our escalation. Our goal is that no patient is off monitor for greater than an hour unless they have notified us in the monitoring room. For example, my patient's going for endoscopy procedure, then we would know that that patient, of course, would be off their telemetry monitor for a period of time, or if they're going to another area. But if it is something as easy as leads off or the pads need to be changed or something along that line, then the expectation is that either the tech or the nurse needs to have that done within 15 minutes.
Okay, great. And Wendy, I wanted to ask you this one too. This is a very interesting one. How did you change the cultural? How did you change your culture to the AHA and ACC guidelines?
That was a little bit of a struggle. We did that research. We decided to take that to our cardiac leadership group first, and we let them review the AHA guidelines, and then we've made a proposal of 3 options that they could choose from. They opted to keep the protocol that any physician can order telemetry for their patient. We kept it embedded, as I said earlier, in the cardiac, neuro, and pulmonary and ICU power plans, so that those groups of patients, it's an automatic assumption that you want continuous monitoring. And then our medical team agreed that if it is outside of those areas, that the physician needs to have a criteria that the patient meets before putting them on telemetry. We then took that to the medical executive committee with that recommendation from our cardiac medical team, and it was a little easier once we had the buy-in from the cardiovascular team, and our medical director was able to take it with us to the MEC, talk it from a clinical perspective and how important this was. It was amazing. They came to the table and said, it's time for us to do this. I think because they had been part of the issue where we were experiencing opportunities for failures in telemetry monitoring when we were having wait lists, we didn't have enough monitors for people. I think they saw that we really needed a criteria for selecting who's on telemetry.
Okay, great. And I want to add one last question in here for Dale. Dale, has any of this been implemented in pediatrics? And if so, what is the ratio of patients monitored per tech?
Well, in my practice with Phillips, I have seen it implemented in pediatrics, and I don't think that the ratios are necessarily any different at that particular facility. I don't know that there is anybody that has ever looked, should pediatrics the ratios be any different between that and adults. You're basically looking at a rhythm and at a sector. So I would imagine you would see a lot more alarms with your pediatric group simply because they're an active group. But other than that, the ratios should not necessarily change.
Okay, wonderful. Well, that concludes the time we have available for questions. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. Thank you to our audience for joining us. Thank you, Wendy Cantrell, John Devanzo, and Dale Roberts for your presentation. Thank you to our sponsor, Phillips. Thanks again for joining. This concludes today's program. Have a wonderful afternoon.
Thank you very much. Ladies and gentlemen, this now concludes our presentation. You may disconnect your phone lines and log off the webinar, and have a great rest of the week. Thank you.